Welcome to the IDEX Continuing Education Series.
Thank you for joining us today or this evening for the second part of our webinar on the minimum database. Last week we went through discussing sort of some general aspects of the minimum database, the importance of baseline testing, talked a little bit about reference intervals, and then addressed the importance of a complete blood count and a biochemical profile. So, we'll sort of just quickly review the minimum database again there, but today our focus is going to be on the urinalysis, looking at what the components of the urinalysis are and how important it is, and then we'll look at some examples of disease-specific testing. So, we discussed last week the question of, there's always that, people raise the question of like, is the minimum database necessary? Is it appropriate? Is it going to be helpful? And I guess, we all see patients, well, when we're talking about sick patients, we all see some sick patients that come in and you get a history, you do a physical exam, and the cause of the illness is not apparent based on that. So in those settings, doing the minimum database with a CBC, a chemistry profile, and a urinalysis can give us some invaluable information. There are times that doing that testing will tell us that what's wrong with the patient. We might find signs of inflammatory disease or a metabolic disease or things like that. There are other times where it won't give us a specific answer, but it serves to rule a lot of things out so that we can focus on other potential causes of that. We also address that sometimes you just see patients that are just off colour. So the client will come in and, they're just not quite right. And again, there's nothing specific on the history or physical exam to give you a clue as to what's wrong with them. So in that setting, most oftentimes if the client is worried that there's something wrong with them, there often is. So the minimum database can be helpful in that setting. The other situation is we might have patients where we can be fairly comfortable from the history and physical exam as to what's wrong with them. So for example, a puppy with a gastrointestinal foreign body or things like that we can palpate and they're vomiting, and when we have a pretty good idea as to why they've got those clinical signs. But in that setting, the minimum database is still helpful for us to look to see what effect is that problem having on them. Generally, do we see signs of inflammatory disease or dehydration? Are the electrolytes, being affected by the vomiting? Are we azotemic? Do we have secondary changes in the liver? So, that's going to be important. And, sometimes if we're looking at wellness profiles, that minimum database will give you value the day you do it, but also by helping us determine a baseline for that patient and setting an individual reference interval for them, it can give us some value into the future. But as we said before, really important, the minimum database does not replace a history and a physical exam. It's to be done in concert with that. So that it's giving us extra information. It's not replacing the history and physical exam. So just briefly reviewing the minimum database, the CBC should be a true complete blood count. So giving us, the red cell mass, so red cell count, hemoglobin, hematocrit, give us the red cell indices, give us a reticulocyte count, because even in non-anemic patients, that can be helpful for us. We need a white cell count with a 5-part differential. Ideally, we need to know if there's a left shift, and we need an accurate platelet count on the parameters. With the modern chemistry profile, that full chemistry profile with electrolytes and SDMA is going to give us that broad information to help us, evaluate what's going on with that patient. But today we're going to address the urinalysis and disease-specific testing a little bit more. The urinalysis we need to help us interpret the chemistry profile, and it can give us specific information about the urinary tract. And the disease-specific testing are those things that we're not going to do in every patient, but we'll decide based on the presenting complaints and what we find on the bloods, and urine, whether we need to do more testing. And just reviewing last week, when we look at the chemistry profile, there are some parameters. Your population-based reference intervals are useful for us, but there are certain situations or certain parameters that looking at results in health, previous results in health on that patient, give us an extra layer of information. And this was from a paper published a few years ago in the Journal of Veterinary Clinical Pathology, and showed that sort of glucose, triglycerides, phosphorus are fine to assess with a population-based reference interval, but many of the other things in a routine chemistry profile, we get that extra layer of information by looking at previous results, and using things like VetConnect Plus can help us present those results all together so that we can easily see those previous results to determine if we've had significant changes. So, that cat or dog that's run at a creatinine of 120 for most of its life, if it then goes up to 140 or 150, it may still be within the reference interval, but that's giving us a clue that there's a deterioration in their renal function and it needs further evaluation. So, but let's move on today to looking at the urinalysis. And with that, when we're doing a urinalysis, it is ideal to do a complete urinalysis. So that means looking at the physical properties of the urine, so colour, clarity, and concentrating ability, the chemical analysis, which is the dipstick, and then a microscopic examination with that. So looking at the urine sediment to see if we're seeing any significant changes there. Obviously, doing the microscopic exam is the more time-consuming part of the urinalysis, and sometimes it gets left out because of that. But I would encourage you, wherever possible, to include that microscopic exam because it can certainly provide us with useful information. Obviously, there are different ways that we can collect urine. The simplest way is often to get a voided sample. Often easy in a male dog, just taking them out for a walk. Maybe a little bit more challenging in some female dogs. And obviously in cats, one way we can potentially do that is if it's a cat that is prepared to use a litter tray, to use non-absorbent litter. You can get those sort of bead type ones or crystal ones that don't absorb the urine. It'll just go down into a clean litter tray. Or if you've got the cat in hospital, just even things like use syringe caps and stuff like that can be something that the cat can scratch around in. But we can easily collect the urine after that. Obviously, the beauty of a voided sample is non-invasive and in a lot of cases a relatively simple way to collect the urine. There is that potential for contamination, from, the prepuce or vulva, skin contamination. So we always have to interpret the results a little bit in light of things we're seeing on the sediment. So, if you're seeing mixed bacteria and things like that, it certainly could possibly be the result of contamination. And, voided samples are not ideal for doing urine cultures on, but guess what? If that's the only sample we can collect, it's better than nothing. And I'd have to say, even though we would often consider a cystocentesis sample the preferable sample to collect for doing a urinalysis and culture, let me tell you, a voided sample is better than no sample at all with that. So, if for whatever reason, uncooperative cat or dog, a very, fat dog that's going to be difficult to do a cystocentesis on, don't discount collecting a voided sample with that. I must admit, I don't catheterize patients very often these days to collect urine samples. When I was in practice when I was younger, which is a little while ago now, I would sometimes catheterize male dogs to get a sample. Some people can catheterize female dogs very easily, some can't. It's not something I find very easy to do. And obviously catheterizing cats is something we need to do at times, but not always straightforward. So for me, the main time I'm going to collect a catheterized sample for urinalysis is if I'm needing to put a catheter in for another reason. So, a blocked cat, a patient with dysuria that we're catheterizing to, see if if the urethra is patent and things like that. They're the times I will collect a catheterized sample. Keep in mind, even though we can sort of clean the skin and around the prepuce or the vulva, there is still some potential, contamination from the external world and urethra with that, but potentially less so than with a voided sample. Obviously, cystocentesis is nice for getting the cleanest sample possible without contamination from, the external genitalia and things like that. There are some, a lot of cats, it's reasonably straightforward to do. In dogs, either blind or with using ultrasound guidance is certainly an option. There are some times I won't collect a cystocentesis sample. So, for example, if it's a patient that comes in and when you examine it, it's got petechiation or ecchymoses or signs of hematomas or bruising on the skin, I am not going to do a cystocentesis on that sample if there's any concern on history or physical exam of a bleeding disorder. I'm always very reticent to collect a cystocentesis sample from that middle-aged or older entire female dog that's not feeling well, that was maybe on heat sort of 4 to 6 weeks ago. If I have any concern of a pyometra, if I'm going to do a cystocentesis, I would rather do it under ultrasound guidance. I don't want to do it blind because the bladder is really close to the uterus, and there's that very unpleasant feeling when you do the cystocentesis and you start getting suppurative material out. We want to avoid that. Um, and the third time is if I've got a patient that's clearly got an abdominal effusion, I'm not going to do a blind cystocentesis because it's difficult to know if you're collecting a urine sample or you're getting the abdominal fluid. You can potentially do it with ultrasound guidance, but a blind one is going to be a little more challenging in that setting. Obviously cystocentesis, has some risk with it. We can sometimes get a little bit, you might get a little bit of blood contamination. Very occasionally there can be rupture of the urinary tract, but that's not likely. So, if we can, it's a good way to collect the urine sample. So when we're looking at the physical properties of the urine, we want to record the color and the clarity. Clearly if it's red, we're worried about pigment, either entire red blood cells or hemoglobin or myoglobin. If it's very cloudy, we're worried about things that could be in the sediment with that. The specific gravity is going to be really important for determining, if you have a patient that's azotemic, is it likely pre-renal or renal? In patients that are presenting with potential polyuria and polydipsia, we expect the urine to be very dilute. If it's very concentrated, you then have to question truly how polydipsic that patient is, by knowing is the urine, if we've got a patient with, PUPD, there's the list of differentials is potentially more limited in a patient with hypostenuria than in a patient with isostenuria. So it can give us valuable information. And don't be afraid to be doing this more than once. So if you've got a PUPD patient, don't rely on a single sample, collect some first morning urine samples that you can get at home to see if they're, persistently, isostenuric or lowered concentrating ability. Obviously over time we've change the way we interpret specific gravities. When I was at vet school, we were told to be considered renal failure, it had to be isosonuric, which, depending on who taught you, was 10.8 to 10.12 or 10.8 to 10.15 specific gravity. I think we often more look at now and ask the question, is the specific gravity appropriate or not? So, in a cat, if it's isotemic and the urine concentration is 1020, 1025, whilst that might not be isosonuric, that's not an appropriate concentrating ability for a cat that's isotemic. When we look at the chemical analysis, there are some things that we're looking at there. pH may give us an idea of, systemic disease, acidosis or alkalosis. If we've got a urine that's got a very high pH, that's sometimes the result of storage, can be postprandial, sometimes proximal tubular disease, things like a renal tubular acidosis can result in that. Some infections can result in that. So the pH is important to look at. Glucose and ketones are obviously important when we're assessing patients for diabetes. In a patient that presents with, PUPD, weight loss, potentially polyphagia. If you've got a patient that's glucosuric, hypoglycemic, and plus or minus ketones, we're going a reasonable way towards diagnosing, if they're a diabetic or not. Obviously, we can have that challenge in cats sometimes. That stress can put their blood glucose up. So if their blood glucose has been up for long enough, we may get some glucosuria in the absence of, diabetes in that setting. Glucosuria in the absence of hypoglycemia always raises that concern of proximal tubular disease. So the proximal tubules are not able to resorb glucose as they normally would. Primarily ketones we think of in the situation of, complications with diabetes like ketoacidosis or at least ketonemia. Even though there are the three ketones in the blood, the beta-hydroxybutyrate, the acetone, and the acetoacetic acid, we're only detecting the acetoacetic acid and acetone in the urine with the strips. But we can occasionally see ketones with, catabolic diseases, very high protein diets, and things like that. The blood strip can be the result of intact cells or pigment. So looking at a sediment can give us an answer with that. Or even simple things like if you've got red or discolored urine, spinning it down. If the supernatant clears with spinning it, it was intact cells. If it doesn't clear, there's likely pigment contributing to that. And remember, some patients with significant muscle injury, trauma, snake bites, and things like that can have very discolored urine from myoglobin, and that's going to react with the blood strips. We're going to look at bilirubin a little bit differently in cats and dogs. Dogs can, their kidneys have the ability to conjugate a little bit of bilirubin. So having some bilirubin in the urine in a dog is not necessarily an indication of underlying pathology. If you're getting a fair amount of bilirubin in very dilute urine or really strong bilirubin urine in more concentrated urine, we need to pursue that further. But 1 or 2 plus bilirubin in urine with some degree of concentrating ability in a dog is not necessarily always going to be a concern. Whereas bilirubin in a cat's urine is always an issue. So if you've got bilirubin urine in a cat, that is something that we need to be pursuing further with that. The white cell strips on urine, the urine test strips are not very useful in dogs and cats. Even if you get a positive on that, it is something that we should always be trying to confirm by looking at urine sediment to see if that's true. Protein always becomes a little bit of a challenge in urine for a few different reasons. First of all, the urine test strips are primarily detecting albumin. They're not super sensitive, so you have to have a little. They're not going to pick up really low concentrations of albumin. We always need to interpret the protein in light of the sediment, because an active sediment may push the urine protein level up. And the other thing to consider is urine concentration. So 2 plus protein on urine of 1050 concentration is very different to 2 plus protein in urine of 1010 concentration. There is a lot more protein in that dilute urine to be causing a 2 plus reaction than there is in concentrated urine with that. And it gets very subjective in trying to say, oh, well, it's 10, 20 urine, it's 1 or 2 plus protein, maybe that's okay. We have to be cautious about trying to make those interpretations. So that's where we need to sometimes consider doing further evaluation of the protein. Keep in mind that proteinuria, we're interested in renal proteinuria, but proteinuria can also be pre-renal. So if you've got significant hemoglobinuria or myoglobinuria, that's protein. It's going to cause a positive reaction on the dipstick. Those very occasional patients with multiple myeloma, remember that's a plasma cell tumour producing immunoglobulins. So the light chain of the immunoglobulins can get into the urine. You're not necessarily going to detect that with the dipstick, but with other tests like the old SSA test, the turbidity test for looking at urine, can detect those. But that's a pre-renal cause of protein. Probably what we more commonly have to try and rule out is post-renal causes of proteinuria. So if we have a lot of casts, a lot of debris, a lot of white cells, bacteria, you've got to have a fair number of red cells to cause a protein reaction. But if you've got a increased protein on the dipstick, we really need to look at the sediment to see if it's active or not. So we worry more about proteinuria, renal proteinuria, if we've got that protein with a bland sediment. And there are things, it's getting a little bit older now, but the Journal of Veterinary Internal Medicine had a consensus statement, a few years old now, but on proteinuria. It's a really nice resource. You can just search for it online. They're open access for that, and it goes through the proteinuria in a lot more detail. So what are the indications for assessing urinary protein further? Well, I guess if we've got a mild but persistent proteinuria with a bland sediment, if we have a really significant proteinuria on a single sample with a bland sediment, in a patient that's hypoalbuminemic, remember albumin's going to be low because it's not being produced, so liver failure or inflammation, or it's being lost through the kidneys, through the gut, through vasculitis or hemorrhage. Looking at the red cell mass and checking liver function and checking a urine protein level are simple things to look for that cause of hypoalbuminemia. In a patient that's hypercoagulable, so a patient that's maybe got signs of significant thromboembolic disease, if you take yourself back to physiology, which sometimes might give people PTSD, but remember that there's a protein called antithrombin that helps sort of moderate coagulation to stop it getting out of control. Antithrombin is a little bit smaller than albumin. So if you've got a protein-losing nephropathy, you're going to be probably losing antithrombin as well. And if that level gets low enough, they can be hypercoagulable. Remember, assessing the degree of proteinuria is something that's part of the IRIS staging scheme for a newly diagnosed renal failure patient. So we need to do it there. And obviously, if we've had a patient that's proteinuric, that is severe enough for us to be treating, we need to monitor that proteinuria to see if they're responding to therapy. So the urine protein creatinine ratio is the way for us to do that. By doing that ratio to creatinine, we are removing the variable of urine concentration from the equation. So it's a more objective way of looking at it. You can do it at the reference lab, you can do it on the catalyst. What I would say to you is, as I always, never do a UPC without having checked that the sediment's inactive. And if you have a patient that's proteinuric that you are monitoring, there can be some variation between different methodologies for measuring it. So if you started measuring it in the reference lab, keep doing it in the same reference lab for monitoring response to therapy. If you did it on the catalyst, keep doing it on the catalyst, but try not to switch between the methods because that makes it a little harder to monitor. The other thing is if you've got a patient with fairly marked proteinuria, there can be quite a bit of variation from day to day with how much protein is being excreted. The suggestion is theoretically we should probably get three consecutive urine samples over 3 consecutive days, do a sediment exam on each of them, and then run a UPC on all three of them and average those results. That gets a little expensive doing that 3 times. So the second alternative is to collect those three urine samples over consecutive days, do a sediment exam on each of them to make sure there's no active sediment, and then on day 3, collect equal volumes of each sample, pool them together, and then run a UPC on that pooled sample, and that's giving you the average UPC over the 3 days. So if one thing we can take away from the talk to the discussion today, consider doing urine protein creatinine ratios if you've got that mild persistent proteinuria or significant proteinuria when you know the sediment is inactive. When we look at the microscopic analysis of urine, one of the other things that can be a little bit challenging about doing the microscopic exam is it's a little bit more time sensitive. So ideally, the urine sediment exam should be done while the urine is still warm and steaming, because then we haven't had time for anything to change. Beyond about 30 or 60 minutes, we can potentially get some changes in cells, casts may break down, bacteria could die or multiply. And if a sample is getting particularly old, if the pH changes, crystals that were there might dissolve, crystals that weren't there might form. So a urine sediment exam done a long time after the urine was collected can be challenging to interpret in that setting. So it's really important for us to try and do the sediment exam as soon as possible as we can after the collection of the urine. And obviously, we're looking for things like, as we said there, red cells, white cells, casts, crystals, microorganisms, non other cells like other than red cells and white cells, things like epithelial cells, which could be squamous or non-squamous. So that's the sort of thing we're looking for with that. For the microscopic analysis, obviously a cystocentesis sample is preferable, but if we can only get avoided, that's what we'll deal with. The urine concentration can affect what we find on that. The sediment is going to be denser in a concentrated sample than it is in a very dilute sample. Ideally, what we should be doing for the microscopic exam is centrifuging the urine at a relatively low speed for 5 minutes, put some urine on a slide, put a cover slip on it, leave it a few minutes for everything to settle under that cover slip, and then do an examination with that. The question often comes of, do we add a sediment stain to that or not? One of the challenges of using sediment stains is they can tend to dilute out the sediment, so it can be, spread things out a little bit with that. And the other thing with some of the sediment stains is there's the possibility that they have their own microflora with that. So you've got to interpret that with caution. The other challenge we have sometimes when we're looking at the sediment is, finding bacteria. It's important. We obviously want to look for bacteria on the wet preparation. So rods can be a little clearer. If you're seeing rods there, they likely truly have an infection. Cocci can be a little harder because other things like debris and bubbles and things can sometimes look like cocci. There were some studies done a few years ago looking at cats and dogs, comparing what we call a wet preparation, so just looking at the urine sediment, comparing if you thought you saw bacteria on that, how many positive cultures, how many negative cultures did you get with that? And, in dogs, sensitivity is reasonable. We're going to pick up most infections with the wet prep, but the specificity was poorer. We got a reasonable number of false positive results with that, where you thought you saw bacteria on the wet prep, but nothing showed up on the culture. Another alternative, if you're questioning whether there are truly bacteria there or not, is to spin down some urine, get the little pellet at the bottom, resuspend it, make a smear with it like you're doing a blood smear, but about halfway down the slide, pull the spreader slide off, and you will end up with a thicker part of, a denser part of the smear there. Air dry that, and then stain it with Diff Quick. Doing that dry cytology preparation increases the sensitivity a little bit in dogs, but significantly increases the specificity. And in cats, the specificity is in the 50s. With a wet preparation, you can improve that into the 80s or 90% range with doing that dry preparation and a cytology prep. So, if you've got, obviously cultures get a little more expensive. It's a way of trying to, with a fairly simple test in-house, get a sense of, are we likely to get a positive on that culture or not? So keep that in mind. And obviously, if you have, if you want to sort of get something on how to do that, let us know, and we can supply that information for you. Obviously, now there's the alternative of some automated urine sediment analyzers that make things a lot simpler, because more likely to process fresh urine. It prepares it and examines it the same way every time, so they can certainly have their advantages. I guess now moving on to the disease-specific testing that we're thinking of when we talk about the minimum database. So as we said before, these are not tests that we're going to be doing on every single patient. They're ones that we will do based on the presentation, history and physical exam, and potentially things that we find on our minimum database. So for example, the image there at the top right with that cat, if you're getting a cat over 7 or 8 years of age that, has appropriate clinical signs for hypothyroidism, I would add a T4 to the minimum database. I would even consider that, as part of a pre-anesthetic screen on older cats, that's worth checking. I've got a picture there of a SNAP CPL test, and I'm going to be very upfront with you. Clearly, doing this presentation, I work for IDEX, but the CPL, the pancreatic lipases, so CPL and FPL, they're not perfect tests. The truth is, we don't have a perfect test for diagnosing pancreatitis, but the CPL and FPL are our best serum tests for looking for pancreatitis, and we can use those in concert with the other blood results, the clinical signs, what we might find on imaging like an ultrasound. But the signs in dogs can be sometimes a little more obvious, and the CPL is pretty sensitive. So a negative result is actually helpful to say it's really unlikely that that patient has pancreatitis if the CPL is negative. A positive result means it could well have pancreatitis, but we can get a few more false positives. There are times where CPL, the pancreatic lipase and ultrasound disagree. Sometimes the ultrasound's right, the pancreatic lipase is wrong. There are also situations where it's the other way around. Ultrasound itself is not 100% sensitive or specific for pancreatitis. With cats with pancreatitis, the signs are really vague. Lethargy, inappetence, weight loss, and dehydration are the most common signs. And that can be a lot of diseases that will present like that in a cat. So if you've got that patient, that feline patient with those vague signs that you don't find much on your routine bloods, considering the FPL could be an option. For a lot of you who are, well, probably a lot of you are younger than I am, wouldn't have encountered the image on the bottom left very often, but that's heartworm. Back in the days where we might do, microfilarial tests, obviously now we do more antigen tests, but, in a patient with that, hasn't been on heartworm prevention, we might include a heartworm test in the minimum database, or in a patient with clinical signs that raise suspicion of it, with some respiratory signs, we would include that testing. We've got the lovely picture of a fecal sample there. I think, doing fecal parasitology is something we probably don't do enough of. In patients with gastrointestinal signs, including diarrhea, it should be one of the first tests that we're doing with that, because even just to rule out some of the common parasitic causes, we want to be taking that step. There's different ways we can do parasitology. If we're worried about Giardia, we can do a wet mount looking for the motile trophozoites. Not especially sensitive, but if we see them, it's helpful to tell us. You can do a fecal flotation in-house with your simple flotation. Challenge with those is they're not better than doing no fecal parasitology at all, but they're not especially sensitive with that. There are techniques we use in the laboratory that are more precise. So in the lab, we do a centrifugation flotation technique. So using zinc sulfate at different specific gravity of solution. So it's the flotation with some centrifugation, and it significantly increases the sensitivity from a simple flotation to doing that technique. And also it has the bonus of, guess what? You don't need to be doing that nasty fecal in the clinic. And we have scientists who are doing that all the time. But now we also have tests that can take us even further with that. So there's now the availability of antigen testing for the common fecal parasites. So roundworm, hookworm, and whipworm, we can also do Giardia with it. So what we're looking for from that is antigen from the adult parasites. So it can definitely increase our sensitivity. So, to have a positive ova and parasite test, we've got to have a dual sex infection that's been there long enough to be producing ova, and they have to be shedding at the time we collect the fecal sample. Whereas if we're doing the antigen testing for that, doesn't matter if it's a single sex infection, doesn't matter if it's a pre-patent infection, doesn't matter if it's not shedding, because we are detecting antigen from the adult parasites. So, testing has shown that with roundworms, we're probably detecting half as many again infections with combining the centrifugation flotation technique with antigen testing. And for whipworms and hookworms, we're more than doubling the number of infections we're detecting. And whipworms can be so challenging sometimes with the intermittent shedding of the ova. So it's a good thing to be considering. But if you're just using it as a routine part of preventive care, the antigen test alone is fine. If it's a patient with diarrhea, it's good to combine it with the ova and parasitology. So you can be looking for other things like coccidia and stuff as well. And that's something that can be done in the laboratory. Based on the patient, we may do other testing. I've got an FIV, FLV test on the right there. In a cat that's unwell, has cytopenias, a cat with lymphoma, things like that, we should be checking for FIV and FELV. Yes, the incidence of FELV is getting lower in Australia, but we still do sometimes see it and can be associated with disease. So doing the antigen test is important because the disease incidence is low. It can affect the positive predictive value of the tests. So then following that up with PCR can be useful. If they're positive on both, we know for sure they've got an infection. For FIV, if you've got that positive and the question of is it truly infection or is it a post-vaccinal thing that we're getting that positive? You can do a PCR to confirm that, because if it's positive on PCR, they're truly infected because we're finding the DNA of the organism in their system. I've got dexamethasone there for thinking of things like, if you've got a patient with consistent clinical signs of Cushing's, obviously we're primarily talking about dogs with this, then it's very reasonable to do adrenal function testing. I'd have to say to you, I'm probably a little bit old school with adrenal function testing. I need a patient with some clinical signs. They don't have to look like a textbook case, but we need something clinically to hang our hat on. Just having an elevated alkaline phosphatase is not enough of a reason for me to do adrenal function testing in the absence of clinical signs of it. So just keep that in mind. Obviously, other adrenal function testing like ACTH stimulation tests, we may do for monitoring a patient on therapy with hyperadrenocorticism. There's some other tests that we may consider in certain situations. We've talked about the UPC ratios before, so we won't address that now. But fructosamine, it's not a test we necessarily need to be using routinely. But, there are some cats that it's difficult to know if they're diabetic or not when you first see them, that are hypoglycemic, glucosuric, but they're unwell, they've got some stress, and you're really trying to determine, is that persistent? So the fructosamine is going to give us an idea of the average blood glucose over the previous 10 to 14 days. So if it's elevated, it's telling us it's more likely being a persistent elevation in blood glucose. Bile acids are not going to be a test that we're going to do routinely on every patient that we're doing a biochemical profile on. But in ones that we've got consistent clinical signs, so a patient with neurologic signs, with seizures, a younger dog or cat that maybe has neurologic or GI or signs of urinary tract disease with things like ammonium urate crystals, we may deem that, or significantly elevated liver enzymes, we may deem that we need to measure bile acids. Can do that in the lab. Very soon we'll be able to do that in-house on the Catalyst. The we may use bile acids sometimes for, for example, a patient on phenobarbital whose liver enzymes are creeping up, but the alkaline phosphatase can always be a little challenging to interpret in that setting. Bile acids, if they're not filling 100%, may give us some evidence of whether they're getting some hepatotoxicity with that. There are certain patients we may do therapeutic drug monitoring. So, a patient on phenobarbital or potassium bromide that's got poor clinical control of seizures, we may do drug levels with that. If a patient's having problems with cyclosporin, we can measure drug levels with that. We don't use as much digoxin these days, but in patients on that to manage arrhythmias, we may monitor that. Things like the cardiopet test, it's by no means a replacement for doing ultrasounds on patients with suspect heart disease, but it can be useful in a patient with suspect heart disease, in a client who maybe doesn't want to go straight to an ultrasound because of the cost, to get a sense, in that sort of middle-aged or older little terrier that's coughing and has a murmur and also increased tracheal sensitivity and has a big heart on chest films, is its heart under stress or not? The BNP goes up when the myocardium's been stretched too much because of increased preload and fluid retention. It then causes release of the BNP or things like hypertrophic cardiomyopathy. There's a snap test for it, so you may use that. You get in a cat with suspect cardiomyopathy, or even as a pre-anesthetic thing, if you get that older cat coming in that, that's having an anesthetic, that, you hear a murmur or there's a gallop or maybe an arrhythmia, might be a way of trying to get a sense, nice and simply before the procedure, is their heart under stress or not? Not by any means suggesting that's going to be a routine thing. It will just be on particular patients. There are some patients based on their clinical history that we may want to do microbiology on. A patient with signs of urinary tract disease, or, the patient with significant ear disease, or, an abdominal effusion that where we're worried is inflammatory. If we've got urinary tract infections based on, our clinical signs and sediment exam and things like that, doing a urine culture is important. First of all, so we know what organism it is, we know the sensitivity, and especially if they're getting recurrent bacterial infections in the urinary tract, beyond beyond looking for underlying disease, we need to know the culture and sensitivity results because it's good antimicrobial stewardship with that, which is obviously very important these days. PCR testing may be indicated in certain circumstances. So, for confirming FIV or FLV infections, a dog that presents with acute kidney injury, we may want to check for leptospirosis because that's a potentially treatable cause of acute kidney injury. In diarrhea patients, in coughing dogs or snuffling cats to try and determine, what the infection is. So there are certain situations, again, it's not by any means going to be a routine test, but there are some patients that we will consider doing that to give us an extra layer of information. As with what we talked about last week with the CBC and chemistry, always really important to look at things like previous results, relate the things you find to clinical signs and consider the individual reference intervals. I don't know why I put C-reactive protein on this page and not the page before, but CRP might be a test, very much a dog test, not useful in cats, but an acute phase protein that can give us a sense of is there inflammatory disease or not. So in a patient that presents, a canine patient that presents unwell, the CRP will go up before the white cell count goes up. So in that unwell patient where there's not an obvious cause on the bloods, we may add a CRP to say, is there inflammation or not? You can use it in patients in hospital to try and get a sense of, is there inflammatory disease improving or worsening? So for example, a pancreatitis patient that's not doing well, you might, if we have a CRP at baseline, you can monitor that, and if it's going up significantly, it makes you worry that their inflammation is getting worse. It also has potential uses for monitoring response to therapy. There are some disease situations where it's not straightforward to get the primary sample again. So for example, a patient with immune-mediated polyarthritis, if we're at that point of determining are we safe to start tapering medications or not, you don't necessarily want to do another joint tap for that. It's expensive and a little more invasive. If we've had a CRP at baseline and then we measure it again, if that CRP is still elevated, I'm not going to want to taper their prednisolone or immunosuppressive therapy at that stage. Whereas if it's back to normal, I'd be more comfortable to taper. There's some paper published a few years ago in Journal of Veterinary Internal Medicine that looked at treating dogs with bacterial pneumonia. Some they treated for a set duration of therapy. Others, they guided the length of therapy using CRP. Once it was normal, they treated them for a few more days and then stopped. The group of dogs that were had the therapy guided with CRP had a shorter duration of antimicrobial therapy, which is good for antimicrobial stewardship, but no increase in the rate of relapse after therapy. So that's important. Just really briefly touching on, we've talked about the minimum database with sick patients over the last couple of weeks. But keep in mind, preventive care testing with a minimum database can give us useful information. This study was published in the AVJ in 2016. It looked at 406 dogs and 125 cats that were well on history and well on physical exam. And they had CBC chemistry and urine where it was collected done. There was 6.2% of the dogs and 19.2% of the cats that had significant changes on the CBC and chemistry that would warrant further investigation. And a big group in the middle that had mild changes that may not need to be investigated. And of the 406 dogs, only 55 had no changes. And of the 130 cats, only 26 had no changes. So, there is value in sometimes in doing preventive care, especially as patients get older, to try and find things earlier on. And there was a study published in the Journal of the American Animal Hospital Association back in 2018, I think it was, where they looked at a huge number of patients, like in the multiple thousands of patients, where they looked at well patients that had CBCs and chemistries done, and there were significant numbers of patients that had changes when they were well. It was 1 in 7 of the adults, 1 in 5 of the seniors, and 2 in 5 of the geriatrics for cats and dogs had changes that would warrant further investigation. So there can be value in doing testing in well patients as well. And this was like 260,000 patients that they reviewed in that study. So that's where we're up to today. So happy to, if anybody's got any questions, Kim, I'm happy to try and answer those now. But otherwise, hopefully, hopefully you found that useful today. Just the quick review of the minimum database and looking at the importance of urinalysis, all three components of it, and considering urine protein creatinine ratio testing when it's indicated. And, it certainly wasn't an extensive view of disease-specific testing, but some of the ClinPath testing that may be indicated, obviously other things like radiographs, ultrasound, all that sort of thing come into that as well. But if there are any questions, I'm happy to try and answer them for you.
Well, thank you so much, Graham. It doesn't appear that we've got any questions coming through. Thank you for your time. That was a really informative session. If you missed any of the webinar or you're wanting to view it again, the recording will be placed on the website. You can expect that to be loaded by next week, and we'll send out a communication regarding this. If you missed last week's part 1 episode where we focused more on CBC and chemistry, it's already loaded on the webpage, or you can head across to the YouTube page to view that. We appreciate your time and keep an eye out for further webinars and educational pieces that we're hosting as part of the IDEX Continuing Education series. And we look forward to having you join us again soon.